Hi, I'm Bob Kaiserman for the National Library of Patient Rights and Advocacy. Yosuke Chikamoto, Ph.D., is a behavioral scientist and educator specializing in clinical communication, improving the patient experience and clinician well-being. Dr. Chikamoto has more than 30 years of experience working across academic medicine, healthcare systems, and professional education. His work focuses on how clinicians communicate with patients and families in the realities of modern healthcare under conditions of time pressure, emotional intensity, and uncertainty and complexity. At Mount Sinai Health System in New York, Kaiser Permanente in Northern California, Dr. Chikamoto partnered with physicians, nurses, and healthcare leaders to design and lead system-wide initiatives in physician communication, patient experience, and professional development. His work has emphasized bedside realities rather than scripts, using observation, coaching, and reflective practice to strengthen communication in every clinical encounter. Today, we're going to be talking with him about how healthcare professionals can better communicate with their patients and with each other. We'll also be talking about his recent book, Communicating with Patients, Real Challenges, Real Solutions, Achieving Better Outcomes and Care Experience with the Patient and Healthcare Professionals. Dr. Chikamoto, welcome and thank you for joining us.
Thank you so much, Bob. Thank you so much for a kind introduction.
So my first question is, your book focuses on building meaningful relationships with patients. What are some of the ways that you have suggested to your colleagues in medicine to build those relationships?
Great. So first of all, thank you so much for highlighting this aspect of the emphasis on the relationship because I really strongly believe in the importance of building the real relationship with patients. Otherwise, the actual healing relationship will never happen.
Right.
So first thing is that I would like to emphasize the importance of the authentic communication for the relationship. Unless there is an authenticity in interaction, it's very difficult to create the relationship, true relationship. To address that aspect, I would like to share with you a little bit about one aspect of my work.
Right.
So in my work as a communication specialist or a communication coach, whatever is called, I do not usually have to suggest or teach strategies. Only thing I need to do is to create an opportunity, a safe environment for doctors to reflect on their communication practice and also think about, okay, how would I do differently if there is some kind of situation where the doctors felt, oh, it didn't go quite well. So let me explain why and how I do not suggest or teach strategies. So the why part, it is kind of interesting when we think about ourselves. If somebody tells us, okay, you have to say this or you have to do this, that's not in our vocabulary or in our routine, always our reactive thinking is yes, but yes, that sounds nice, but that's not in my vocabulary. That seems weird. Um, but if doctors come up with their own unique way of expressing certain things, it does have authenticity, and those words really carry a very strong intention behind it. Um, so the doctors want to convey certain type of thing using their own vocabulary that really convey that intention. So because of that, I do not really want to prescribe script. Okay, this is how you say it.
Right.
So that's the why part. Then the second part of how part, how are you doing it? So basically, I will do lots of shadowing of doctors, and I ask them, okay, so how did it go? And they usually say, oh, I wish I had done this. I wish I had haven't done that. Um, but of course, first of all, I will say, okay, what went well for you, so that we can kind of celebrate and confirm the great conversation that they were already having. But of course, after that, we really have to dig into how we will do it differently. So I will ask the doctor, okay, so is there any occasion or any part of your interaction where you wish you could have done it differently? And how are you going to do it once the next time you encounter a similar situation? Then most of the times, I would say 90% of the times, that doctor is going to look inside and they say, yeah, this is what I wanted to convey, or this is what I wanted to accomplish. Okay, that way of saying wasn't quite right. How am I going to be able to say it more clearly and more compassionately? Then they will come up with their own way of saying it. And it is amazing. There are lots of wonderful ways of dealing with it. It's not a cookie cutter type of approach. So I have accumulated so many of those in my database. So that's wonderful. Um, but once in a while, doctors get stuck and they say, okay, I'm just stuck. I can't really come up with any ideas. Do you have any ideas? Then that is the time I share what I have observed with other doctors. So other doctors in the similar situation have done certain thing. May I share with you those ideas? And of course, they will be happy to hear that. So that's the time when I start sharing. So now, I'm going to be sharing some of the examples these doctors have done, but I want everybody to be filtering that kind of information, saying, oh, does it feel authentic to me or not?
Right.
So the first example that I want to mention to you is it's because of the common complaint. I don't really want to say complaint, but the concern from patients that we hear at the hospital, which is my doctor doesn't listen. He doesn't seem to be listening. She wasn't really paying attention to what I have to say. It's a very common one. So with that kind of concerns raised by the patients, I would go see that doctor. And of course, that doctor has already received that note saying that you got the patient complain this, concern this. Then the standard reaction I receive from the doctor is, well, I listen, obviously. Otherwise, I won't be able to make any diagnostics. I can't make any treatment plans, recommendations. So that's what I hear. So, what some of the doctors in that kind of situation have found out is that I listen is not enough. It has to be shifted toward, let me show you that I am listening to you. So I think that is a critical kind of component of the strategy that would really help doctors build the meaningful relationship with patients. So making their listening visible to the patient. So I find some patterns. I want to go into a little bit more concrete level of what I mean by this. So there is some strategy, communication strategy called repeat, rephrase, summarize. And basically, doctors are supposed to repeat back to the patients what they had to say. And sometimes you rephrase it, sometimes you summarize the thing and get back to them so that we are getting, I mean, doctors are getting the right information and they are confirming with the patients. However, what I have been finding is that some doctors find it so difficult to practice this repeat, rephrase, summarize when the patient shares his or her worries, anxiety, depression, um, or when they have some specific request, like, oh, I want antibiotics, or sometimes, oh, I think I need to get an MRI. And sometimes that's true, but sometimes that's not true. And the request part. So those requests that the doctors eventually have to say no to, they really do not want to say, oh, okay, so you want an MRI, you want an antibiotics. So those are the things, those are the pattern that I have seen with some of the doctors. So the solution ideas that these doctors have eventually come up with are, okay, let's make sure we practice this common thing that we've been doing as a standard, even when the patient shares their worries or even questions. Oh, you have this question. I'm going to answer that question after I do examination. Oh, so I understand that you would like to get antibiotics. I will make sure I will do a thorough examination and see if that is going to help your condition. So using that kind of repeat, rephrase, summarize for these worries, specific request questions, those are really the critical one, some doctors have found. Um, and another example, this is a lot more kind of simple example, which is let's um, so doctors really have to always explain lots of things, the diagnosis and also the treatment plans. And even though they try to use or try to avoid some jargons, sometimes or maybe lots of times in a vulnerable situation, patients find it so difficult to understand.
Sure.
But after that, supposedly the monologue of the explanation ends, um, doctors tend to say, any questions? Then any questions while they are almost about to leave the bedside. So that is not really inviting the actual questions or concerns from the patients. So the idea that some doctors have come up with is instead of saying any questions, let's say, what questions do you have? So that definitely you can tell assumes that you do have questions. So what questions do you have? What questions can I help answer? So that's just a word difference, any question versus what questions, but really conveys the intention behind the word, what the doctors really want. Um, but again, the authenticity matters here too. So some people say, "Oh, what question do you have? That sounds so weird. I don't want to say that." Then that's perfectly fine. They find a way that I am really willing to listen to your question. I really want to answer your question. So you could say something like, "Any questions?" And mm, just wait for 10 seconds, 15 seconds before you start leaving the bedside. That helps. Or some other doctors might want to say, I have explained a lot of things today, so I'm sure you have lots of questions. So, any questions? Or maybe you could normalize it by saying, I know that I have explained so many things, and in the situation like you are in, many patients have lots of questions. So, how can I help you? That way, it's okay to ask questions. I think those are kind of communication strategies, and those are the ways that will really help um, patients to feel okay, it's okay to have this human connection with this doctor. So there are so many other strategies or ways of communicating with patients exist. But if I do that, I'm sure I'm going to take up like 2 hours, 3 hours, 4 hours. So let me just stop here and see what question you might have, Bob.
One of the things I would like to ask you is, patients are now experiencing something over the last couple of years. When you walk into your doctor's office, you sit down in the examination room. Typically, the doctor comes in, takes a card, and logs into the computer.
Yes.
So what happens in many visits is that the doctor's looking at the laptop screen more than the doctor is looking at the patient. So in your research and in your strategies, how are you teaching doctors that that is to some patients rude,
Hmm.
um, and then they feel, where's the connection?
Hmm. Right. Because the name is very, very important, right? Patients are aware. As a doctor, you do see who you're going to be seeing for you there.
Right.
That's the one thing that we at Kaiser Permanente, we definitely make sure every single doctor at every single occasion will know whom you are talking to. That's something that we kind of do it in a kind of manual type of way. And in many occasions, the patients have a way that they would like to be called. So that one appears on the electronic medical record. So many doctors go to the computer outside and check, okay, how this patient wants to be called. Is it Mike? Is it Michael? Is it Mikey? Or is it Mr. Smith? Those are the things that they try to do that. Then, of course, once you go in, yes, the existence of this computer, that is always a challenge. We have some habit called invest in the beginning. Once we invest in the beginning and create a relationship with that patient by calling them in the right way, the preferred way, and shake hands if culturally appropriate, and say, um, it's been raining. How did you make it here? Was it okay? Was it difficult? So that kind of social comments to bring the patient into this medical conversation. Those investment really pays off. So that's how we do that. Then we basically say, do not log in to the computer until you you establish the relationship and say, let me log on now so that I can take a look at the detail of your medical history. So I don't want the some doctors really complain about having to use the electronic health record.
Right.
And they kind of blame the computer for not being able to have meaningful relationship. Yes, it is a challenge. However, there are some ways that the doctors can employ to still have meaningful relationship. So by highlighting the importance of logging into the computer and also explaining to the patient what the doctor is doing. It's a kind of interesting. I feel like the computer is a third party in the exam room. All of a
Sure.
sudden, the third party showed up without being announced. So, okay, let's make an announcement. Okay, this is my colleague, the electronic medical record. And some doctors actually do that. Other doctors, it doesn't feel authentic, so they don't do that. But there are many other ways to introduce the computer. Then, when they are looking up the medical history in the past, well, history is in the past, but medical history, you can say, okay, let me check medical history right here. Just articulate what they're doing so that there's no stranger in the room. I
Right.
think that's what is so important.
I would imagine
Um,
you do the same thing when the scribe's in the room.
Hmm.
the medical scribe.
Right,
They just don't walk in, but you introduce them and tell the purpose of them being there.
right. Definitely. And I think, that's kind of one thing that I think I wrote in my book too, but the one doctor who was kind of more matured, he had been practicing medicine for a long, long time, and he was not really um, willing to type in all the information by himself. So he hired a medical scriber. Then this PA, physician assistant, was typing in, looking at the information. But because of the presence of her in the room that is seen by the patient knows she's there. Then the doctor is asking her, okay, could you check the medical record? Could you actually put in this test for this patient? What does it say? So the physician assistant can articulate that back to the doctor. That means the patients can hear it too. So I think
Right.
yes, definitely that's a great way of incorporating the third party.
In your book, you mention a concept called space between words. Can you explain that concept?
Sure. So space. I like the word space because space can be everywhere. As a communication specialist, my tendency is to pay special attention to the words, like what is spoken, what is articulated. But I'm often reminded that, um, one time the Mark Twain said, no word was ever as effective as a rightly timed pause. I mean, coming from Mark Twain, who know how to use words, I thought that was really a cool
Sure.
aspect. And I really, I had an experience, actually several experiences where this words or this phrase really hit me. So let me invite you to a clinic. Let's say I was shadowing this doctor in her interaction with a patient, and this patient needs to lose weight because his hemoglobin A1C control is out. So let's say, okay, you had to lose weight and make sure you're going to control your diabetes. So this doctor is such a wonderful, wonderful doctor who's been practicing so long um, about this diabetes management. So she will start saying things like, um, okay, I know that you have diabetes and you are overweight. I think it's really important to lose weight. In order to lose weight, you might want to start exercising. I'm not asking you to run a marathon. You can start out slowly,
Yes.
just 5 minutes a day, those kind of things. Then the patient is like, yeah. Then doesn't really say, okay, I'll do it. This doctor is gonna start saying, okay, if walking is so difficult, how about this? How about this? So it comes one advice after another. So patients do not have the time to process or to react to it. So that's when this Mark Twain's word really comes to me and it comes alive. Well, you may have lots of great, wonderful devices, but unless you pause there, it's not going to work. So that's kind of one way of um, thinking, yes, the space or the pause that in a timely fashion is very important. Um, the funny thing is that doctors are very, very efficient people, very um, always at the peak performance kind of people. So it's very difficult to deal with silence because they think silence is the sign where nothing is happening. And especially, under the time pressure they have, they don't really want to waste any time. So when the patient doesn't react, oh, that sounds like a great idea. I am going to do it. Well, ignore that necessary space. And they would come up with the next advice, next question, next way of explaining things, all those things. So that's why I sometimes talk with the doctors about this pause in the Mark Twain's aspect. Another way to think about the importance of space for visual people is that like slide or the paper slide presentation or the material, the documents that you have to create for a meeting or the even at the conference presentation. We tend to say, oh, I have to put it into one slide. And we make the margin as small as possible and make the font as small as legible if people are willing
Right.
and reduce the line spacing as small as possible. And what are the results? Well, it's so difficult to read. So if you're so interested, we might read it, but that appearance of the lack of margin, lack of space, make us not want to read it even.
Yes.
Or even if you read it, you feel like, oh, this is just blah blah blah. It's not important. So that kind of appeal to some people who have been somewhat aware of their long, long monologue of the details of diagnosis and treatment plans. I have two other examples of the space. So another very famous space is called out by Viktor Frankl. The I just want to make sure I'm gonna quote it right. Let's see. Between stimulus and response, there is a space. In that space is our power to choose our response. In our response lies our growth and our freedom. I mean, wow. This is such a very powerful saying, but this one is very popular among doctors. For doctors, this is such a great reminder of getting into certain difficult situation, challenging situation, and sometimes you feel like, oh my gosh, why this patient doesn't understand what I'm trying to say? But okay, how to address that? There is that freedom, the space where we can exercise our freedom um, to do a mindful decision. So I think that's one way that the space is really important for doctors, and it's a great reminder. The last one I want to talk about is it's not really the space. I think it's better to say gap, but the humans are ambivalent. That's by nature. Sometimes, oh, I want to do exercise, but I want to stay in bed a little bit longer. I need to check my glucose level periodically, but it hurts. So there are lots of, yes, I do want to do it, but I don't want to do it. All those ambivalence exist. So some doctors found this way of calling out that gap or the space and help them really become aware of the gap and try to walk through that gap. So let me explain to you a little bit with more concrete example. So how for the patient, let's say for a patient with diabetes, so how important is it for you to keep track of your blood glucose level? 0 to 10, what's your number? Then the patient might say, well, it's 6. Then the doctor could ask, okay, so your importance score is 6. Why not five? Then they will start saying, oh, I could have chosen five. I had the total freedom of choosing whatever number. But instead of five, I chose six. Why is that? Then I feel like, oh, yeah, I think it's very important because of this reason, that reason. It is much more effective because that reason that the patient come up with are authentic to them. So it's much more powerful than doctors saying, okay, if you don't do this, you're going to have a high risk for heart attack, those kind of things.
Hmm?
Um, so that arbitrarily created space and ask the patient to move to another direction. Okay, why did you do that? So that's based on the motivational interviewing technique, as many of you may know. But I think that kind of use of space is very important. So silence definitely as an active engagement, we have to be reminded of that. And the margin as a breather. I mean, if you see that kind of very busy slide, you can't even breathe. So margin as a breather. Then the space between stimulus and response as a powerful choice, capability or the power of the power, so ability. And the gap as a potential energy to create a potential energy for determining the direction of where you want to go. So those are like four examples that I kind of feel the importance of the space.
Finally, excuse me, finally, many patients have shared with us they feel that the doctors practicing today have no empathy. They're not related to the patient as a person, rather simply as another patient on the chart on the desk. To me, empathy is so important when you're faced with an illness and you're depending on your doctor to help you get through the journey in terms of what happens now, what happens next. So, how do we change that scenario? Does it start in medical school or at the level of being a resident? How do we teach doctors to be more compassionate and empathetic?
So I think the key aspect that is often brought up is the empathy, right? So
Yes.
can empathy be taught? That kind of things. And many patients say, "Oh, I don't think my doctor have empathy for me." I mean, it really hurt me. In the very vulnerable situation, you really want to be seen as an individual. You want to be heard and you want to be understood. That is super important. One thing that I feel very sorry for those situations, but one thing that I find light in this type of situation is that 99% of doctors don't do that, don't show empathy out of their ill intention. It's not like that. Obviously, there are lots of people who talk about time pressure as a reason why they cannot really show that kind of empathy. Documentation needs for health insurance payment purposes. That actually leads to the part that we have been talking about, the constant needs to use the computer. Then the pseudo conversation with a third party, that computer. All those things make it very difficult for doctors to really see the patient as a person, as an individual. Fragmented care delivery with highly specialized medicine is another reason why they can't. They have very difficult time to show empathy or to be paying attention to what the patients are experiencing. Because, sometimes what is the doctor's role? To do the testing, and is it negative or positive? That's the only thing that the primary care doc or other doctors ask him or her to do. So when the patient start talking about his or her worries or questions, no, 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 it's not my role. So that comes out as the lack of empathy as well. But I also want to talk a little bit about another important aspect of the emotional exhaustion. So doctors are exhausted, and it's because of the time pressure, having to see many, many patients, all those things. In that environment, and the doctors being such a superhero, even when they were growing up, they were the A plus plus students. So they really put the priority on self-care at the minimum. So there is definitely the low priority on self-care. So that leads to that burnout, emotional exhaustion, all those things. Then if you get into a burnout situation, emotional exhaustion phase, depersonalization phase, all those situations, you do not have the uh, ability to show empathy. So I really think that one of the ways to deal with this lack of empathy syndrome is make sure that the doctors start wearing their oxygen mask first before they start helping others. The good news is that in many medical schools, they started really paying attention to the medical students' wellness. So that's a very great sign.
Mhm.
So, how to address the situation a little bit in a more detail? So, I would think that, of course, there has to be a change in how healthcare is delivered and financed, all that kind of stuff. Um, but that might take forever. So, meanwhile, what can we do as more of the practitioner level? I think the most important thing is having honest conversation among doctors or between doctors and nurses, between doctors and patients about this what I call the monster, the empathy. Um, so to become honest, one thing that I am very, very sure about is that blaming somebody or blaming some party is not really a good starting point. So let's have a conversation without any blames. That's how I would start it. So for just as an example, a kind of thought exercise. So you got a phone call from your best friend, and he or she tells you that the father, his or her father, was diagnosed with lung cancer and stage 4. All of a sudden, we have empathy. We feel empathy
Sure.
for my friend and the father. Oh my gosh. But after a while, you start thinking, was he a smoker? It doesn't mean it doesn't change the situation that this friend or the father were in, but we somehow start thinking about it. Then, okay, so if he was a smoker, so what does that mean? Well, if he was a smoker, he is still a smoker. What does it do? How did he start smoking? Maybe he was a soldier at the Vietnam War and he received a care package that had cigarettes in it. And that was the first time he smoked. And since then, he couldn't break the habit. Then does he deserve more empathy from us? Those are the things that
Sure.
really is complex and very difficult. So what I feel about this empathy is that the if we rely solely on this feeling empathy is very, very rocky. So I do not, I mean, feeling empathy is wonderful, but I really want to go a little bit deeper. So there is a concept called interpathy. And this one, I learned it when I was in a seminary studying pastoral counseling and pastoral care. And interpathy concept or approach was developed in the missionary world, where missionaries go to a completely different world, where the culture is different, value system is different, expectations are different. So it's so difficult to feel what they are feeling as if it were my feeling. So that's the definition of the empathy. It's so difficult. So rather than pretending as if we understood what they are feeling, let's be humble and really uh, going on a journey of finding out. So say, I'm not quite sure if I understand this. So please tell me more. That is the kind of approach that we employ in interpathy. And when I share this interpathy approach, doctors find it kind of assuring. They may be relieved because sometimes they feel like I should be feeling empathy, but I just can't. It's so hard to feel. Um, so okay, you don't you sometimes there is an opportunity that you can't feel it. So just ask them. So that's the one way to deal with this empathy stuff. The another thing is your expertise area, patient's right. We have to really say, even though I cannot feel empathy for this patient, patients have to be dealt with or the receiving the care with dignity and respect. So even though the patients have a right to feel what they are feeling. They might feel kind of like angry at the doctor. Yes, that's their feeling, and they have a right to it, and we have to respect that. So I think those are the kind of conversations that we usually have with doctors, and those things happen, at the physician's lounge or in a hallway. It's just a chat we have, and that seems to help doctors quite a bit to address this type of issue. So when should we start having this kind of conversation? Earlier, the better, of course. And earlier, meaning even in like grade school or high school, junior high school, we really have to be taught about the importance of communication, conflict resolution, um, what it means to care for other people. How can we really compromise? All those things have to be taught for everybody, regardless of what career they choose. Therefore, the doctors and the patients, doctors and um, nurses, everybody will have that kind of foundational communication skills. So that's one thing. But obviously, in a medical school, it has to be taught. But the interesting thing is that at a different stage of their career, medical students to intern to resident to supervising physicians, the needs are different. Needs for what type of communication support is necessary varies so much. So definitely in the medical school, people have to be really taught the importance of this type of communication in a conceptual way and some of the examples. Then when you start seeing the patient, not just a part of the visit, but like resident. Okay, they see patients. That is really the time that they really struggle. So that's when we start kind of program with the supervising physicians. Okay, supervising physician, you are supervising this resident. They have to learn this kind of empathy, communication skills. They have to address the patient experience or bedside manner. Okay, so the time that you guys, the supervisors, are taught, they were not dealing with it.
Mhm.
So, okay, let's discuss that. So, having that kind of conversation with the supervising doctors, then that kind of go down to the resident level. I think that was very, very successful approach. Um, then already practicing physicians, it's probably the hardest because they don't have to have the training other than the continuing education requirement, but they have already established their styles of practice. Okay, this is how I do it. If you go see a dermatologist, each individual has a very strict way of doing things because they have to see so many patients. So it's very like um, almost like a clock, Swiss clock kind of things. Um, so in that kind of situation, just a conceptual talk wouldn't do anything. Workshop wouldn't do anything. So that's why I do a lot of communication coaching because my role at Kaiser as well as Mount Sinai was pretty much addressing these communication challenges with practicing physicians, not in the medical students or not in the residency program area. So when I go there as a coach and shadow him or her interacting with their patients, then have a conversation afterward about the communication, it is really the applied. It can be really applied to their real situation.
Sure.
So I think the approach, to answer your question, it has to be taught throughout the life, but the strategy to address that issue has to be different from one time to a different phase.
Okay. Thank you so much for joining us today, Dr. Chikamoto. It's been really a fascinating interview. I'm Bob Kaiserman for the National Library of Patient Rights and Advocacy. Thank you for joining us, and we'll see you next time.